Sure.
Thank you, Venki.
We have 33 participants, Venki, so far, 34. Should we start?
Presenters, can you wait for a few minutes? Is it okay?
Yes, please.
Yeah, no, absolutely fine.
Matrike?
Hello, I'm here.
Hi, Matrika, how are you?
Hi, Meenakshi. I'm very good.
No
Thank
problem.
you.
Can we wait for?
We'll wait, Venki.
Yeah, we'll wait for a few minutes. Video on the
Hi, John. Good evening.
Good evening, John.
Namaskar. This is Indumati Rao from Bangalore.
Namaskara. Happy New Year.
ನಿಮಗೂ ಅಷ್ಟೇ.
Thank you.
Venki, should we start? It's already 4 minutes past.
We wait for one more minute and then we start.
Okay.
Is it okay?
Yeah,
How
sure.
many people? How many are there now? 21 now. Participants. Read WhatsApp message.
Sent a new message. Venki, I've come on field visit. Still not reached home yet. Would you like to reply?
Francisca, can you hear now?
Whom you are asking?
No, actually, nobody is talking now. Because that's the reason there is no sound. Somebody is asking on chat that the sound is not good.
Okay. We all are waiting in silence.
I think Meenakshi, we should start, don't you think?
Okay. Okay. Good evening.
We waited for 5 minutes and I think people.
Yeah. Okay, Venki, I'll start now.
No, thank you.
Good evening, everybody. I welcome you all for this webinar. Before we get into the webinar, I would like to clarify some of the ground rules and some accessibility initiative that we have taken for this process. To begin with, we have 4 sign language interpreters, 2 Indian sign interpreters, and 2 international sign interpreters. So you can pin them. Then we have language interpreters for Hindi, French, and Spanish. So you have a globe symbol below your screen, and it's labeled as interpretation, and you can choose whatever is comfortable for you. You have closed captioning option. So you can also switch on the captioning so that you can have a live captioning services as well if you need. And I request all the participants and the speakers, if you're not speaking, to keep your mics on mute and do not switch on the video, because sometimes there may not be enough internet space available. And also when a session is on or when a speaker is presenting, please do not use the chat option. Please do not use this chat option. You can use it during the question hour, not before that, because it impacts translation. So please refrain from using chat option. And this is also live telecast. This has been live streaming on YouTube. So you can also watch it there, and this program is recorded. And if you have any issues with recording, you can inform us, or yeah, but this program is being recorded. So anything else, Suja?
No, Meenakshi, that's it.
Okay, thank you. So now we'll move into the webinar.
No, photo.
Yes. So, so you can all switch on your video for a minute so that we can take a group photo. So I request you all to switch on your video for a minute.
Now, Meenakshi?
Yes, now for a group photo.
Okay.
No.
Now, NOW. The closed captioning is saying no.
That's a disaster.
No. That's fine. So we can all, Suja, can you support us with this? You can take a photo of.
Yes, everybody just keep smiling for a few seconds till I say it's done.
Okay.
Ferozia, we can only see your eyes. Can you lower your device?
So Praveen Kumar, your
that's
face
it.
is not fully seen. Thank you very much. I'm done.
Okay, thanks, Suja. So now we'll move into the webinar. Welcome to the webinar on poverty, hunger, and disability, the missing link. This is the fourth in the series of webinars, which we've been doing from the last years. And we are focusing, today we are focusing on towards living independently in community with dignity for all persons with disabilities. The previous webinars brought back the focus on the impact of poverty on persons with disabilities. And we also discussed some solutions to address the same. One of the key solutions that came up was focusing on community-based rehabilitation services for all persons with disabilities, particularly those living in low and middle income countries with huge geographical diversities, remote island countries, and so on. The purpose of this webinar is also to ensure that home and community-based rehabilitation is in the proposed World Health Assembly resolution on strengthening rehabilitation in health systems that is to be adopted in the World Health Assembly to be held in May 2023. Currently, this is absent in the World Health Assembly Resolution 76.8, highest attainable standard of health for all persons with disabilities, and in the WHO Rehab 2030 call for action. Today, we will be discussing the impact of community-based rehabilitation on the effective inclusion of persons with psychosocial disabilities and mental health issues. And also, we are highlighting the marginalization experienced by carers of persons with disabilities. Today, we will have 3 presentations. Before that, we will have a short video. And we are very thankful to Mr. Anjanelu for supporting us with this.
నాది చిప్పగిరి, నా వయసు 29 సంవత్సరాలు. నా పేరు అంజనేయులు. నేను బెల్దార్ పని చేస్తాను. నాకు 25 సంవత్సరాలు ఉన్నప్పుడు షోలో మాట్లాడడం వినపడడం, భయం కావడం, కొట్టేక వచ్చినట్ల వినపడడం ఇవన్నీ జరిగేటివి. మా అన్న నాకు మనిషికి బాగలేకుండడం వల్ల స్వాముల తాకి దోలుకొని పోయి అంతరాలు అవన్నీ కట్టేయడం జరిగింది. అంతరాలు కట్టడం వల్ల చెయ్యి కొంచెము బెందుపడింది. ఆ సెక్యూరిటీ సంస్థ వాళ్ళు బలవంతంగా తోలుకొని పోయి నన్ను హాస్పిటల్లో చేర్పించడం జరిగింది. నన్ను హాస్పిటల్లో 3 రోజులు పెట్టినారు. మాత్రలు ఇచ్చి ఇంటికి పంపించడం జరిగింది. టాబ్లెట్లు రోజు వాడడం వల్ల భయము అట్లాంటివి ఏమీ నాకు వినపడడం లేదు. చెవులు మాట్లాడడం అవన్నీ వినపడడం లేదు. అనంతపురంకు పోయి 15 రోజులకు ఒక్కసారి టాబ్లెట్లు తెచ్చుకునేవాడిని 2019లోన. ఇప్పుడు నెలకు ఒకసారి పోయి తెచ్చుకుంటున్నాను. నేను అన్న తమ్ముడు వదినతో పాటు ఉంటున్నాను. తొందరలో నా పెళ్ళి అయిపోతుంది. నేను ఫ్రెండ్స్తో పాటు సినిమాలకి పోతాను. సెల్లులో గేమ్లు అవి ఇవి ఆడుకుంటూ ఉంటాను. అందరితో పాటు కలిసిపోతాను. నాలాగా మానసిక ఇబ్బంది ఉన్న వాళ్ళు గ్రామాల్లో చాలామంది ఉన్నారు. ఇలాంటి వాళ్ళందరికీ గ్రామంలో చికిత్స అందరికీ కల్పించాలని ప్రభుత్వాన్ని కోరుకుంటున్నాను.
Thank you, Suja, for playing that. Now I request Venki to give the welcome address. And Venki, you have 6 minutes.
Thank you. Yeah, thank you very much. Greetings, Happy New Year, and a warm welcome to each and every one of you. Today's webinar is about hope. The 3 presentations today will show how effective psychosocial support services can be with the active involvement of communities and local authorities for people with disabilities to live independently with dignity in communities. Why are these local initiatives so important? Here are some facts. 792 million people worldwide reported impaired mental health in 2017. Okay. This figure forms a whopping 11% of the global population. %75% of these people do not get treatment, or support whatsoever. Mental health conditions also produce economic losses to the tune of $1 trillion US, with depression being the leading cause of illness, mental health, and disability. These figures are overwhelming, but we also need to understand what they mean for vulnerable people with disabilities, especially those with psychosocial disabilities. Here is what we know. People living in poverty are unequally affected by mental illness. Poverty has increased globally since the COVID-19 pandemic. The increase is 3 times higher in rural areas than in urban. The interaction between food insecurity and mental health is one of the main sources of global mortality and disease. People living in socially underprivileged and poor city areas suffer more often mental disorders such as depression, anxiety, psychosis than those who live in high-income neighborhoods. Social cohesion gives people a sense of belonging and a solidarity with community. This combined with gross household income substantially influence individual mental health. Lack of family and neighborhood resources can lead to more stress, isolation, discrimination, and vulnerability to mental disorder. These can further stigmatize people. Family and peer support structures are essential for mental well-being. Community and environmental processes reflect social differences and social inequalities. These directly impact a person's mental well-being. But this webinar is about hope, not about despair. The 3 presentations will show how local interventions in resource care settings are building cohesive, socially cohesive communities for people with mental health. May we observe a minute's silence in solidarity with those who do not get any services whatsoever. Thank you.
Thank you, Venki.
So, Venki, you're done?
Thank you. Yeah, thank you.
Yep. Now, I request Mr. Rajaram to give his presentation. And before that, a small intro note about Mr. Rajaram. Dr. Rajaram Subayan, a psychiatric social work professional, is a mental health practitioner for 5 decades in different capacities, starting from national, then regional, to being psychosocial advisor in international organizations. His highest studies of MPhil and psychiatric social work, PhD, were from the National Institute of Mental Health and Neurosciences, Bangalore in India. Dr. Rajaram has 2 decades of clinical and community mental health exposure, teaching and training at NIMHANS. For 13 years, he worked in Sri Lanka, Uganda, Nepal, Bangladesh, and Afghanistan with families children and communities traumatized by war, armed violence, and abuse. He personally interacted with thousands of affected children and families, building resilience in children and communities, and developing community based curriculum in social work on child protection, both in Sri Lanka and Afghanistan. His niche is improving community mental health, promoting community based psychosocial care and interventions for persons with mental illness, and strengthening therapeutic skills in social work or mental health professionals, community workers, and lay counselors working with vulnerable people. Dr. Rajaram is an international trainer cum practitioner on community mental health and psychosocial well-being, and currently the executive board of Basic Needs India Bangalore, that is the resource building organization in community mental health and development. Over to you, Mr. Rajaram. And you have 10 minutes.
Thank you. Thank you. Thank you so much, Meenakshi. And New Year greetings to all the viewers and the participants. Special thanks to Venki, our convener from IFRA, and moderator you, Meenakshi, and the other resource persons, Dev Kota, and also Dr. Anil Patel, and Smita Sadasivan. Okay, and I'm quite honored to be here to talk about community mental health. And Venki shared with us already the statistics of people in going through mental illness. So I will skip that. Just to say that, Suja, can we go to the third slide? Next. Yeah, only to say that 1 in 7, at least in Indian population, they go through some mental disorders, disturbances. Okay, that you can imagine what huge number of people in need of help and intervention. Next. And yeah, mental illness is quite a complicated one to deal with, because the treatment may be easy to understand, but the myths and misconceptions that people in general they have about mental illness, that is the main block in reaching out persons with mental illness and also treating them and providing all kind other interventions. Okay, every community has different beliefs, misbeliefs, and anything or you can imagine is interpreted as sin or possessions, or could be karma, that is previous birth, whatever we have done, we carry it. And so people fear, it's a kind of a taboo. People fear persons with mental illness, and not many think about treatment or other interventions. Immediately they feel they need tying up, and they should not. So people hesitate to come out and say, yes, there is a member with mental illness in my family. So ultimately what happens is they are hidden, they are locked up, and the illness becomes chronic. And another main drawback in mental illness is that if you don't treat the person with mental illness properly, appropriately, the longer the symptoms remain, our life skills start deteriorating. So people with mental illness, you will see they have, this is what, even after treatment, unless we help them to improve the life skills, they remain affected. That's why it comes under psychosocial disability. Okay, so what we need to do is, they also say that the golden hour is the first 2 years. If we don't treat them during those 2 years, and there's likely the chronicity sets in, and it becomes extremely difficult to rehabilitate and to reintegrate them back into community. Next slide. Yeah. Yeah, we'll go to the next one. So when we talk about treatment, since the families have or improper understanding or misunderstanding of illness, and they don't want to say that there are people suffering through mental illness. Many, they do not know it's mental illness. So they believe quite a few, the local traditional healers. So they don't come to the hospital for treatment because the hospital has effective medical treatment, but they don't want to, they avoid it and then go to various faith healers and traditional healers. Okay, that's another reason the delay or refusal to come to hospital treatment. Next. Yeah. And as we said, there are at least some 10 to 12% of people suffering from various kinds of mental illness and disorders. And if you look at what kind of services we have in the country and how many mental health professionals are available, I'm talking about India, the professionals available for such a huge 1.42 billion people, and looking at the people suffering from severe mental illness, it runs to millions. But if you look at the mental health professionals, there are something like 3,000 to 4,000 psychiatrists, similar number of other psychiatrists, social professionals, psychologists, clinical psychologists, and psychiatric nurse. So if you look at it, the availability of the mental health professionals for such a huge population suffering from mental illness, it's hardly 1% or less than that. Okay, so that's, and added with the myths and misconceptions, 80% of people suffering from mental illness, they don't get adequate treatment, either because of lack of funding from the government, so the facilities are very minimal, and lack of mental health professionals, as I said. And because of all this, many remain untreated, and in this, many remain locked up, chained, and kept inside the house. Okay, and so again, if you wait, and if at all they go to hospital for treatment, then the hospital becomes an institution. And so imagine the family takes the person suffering from mental illness to a hospital nearby and admit him and provide all kind of interventions necessary, what is possible in that hospital. And when he brought back, the community doesn't know what happened in the hospital because they remain in their mysterious beliefs, and they do not know how he becomes improved and how he is back without, meaning minus mental illness. So the myths continue, the misconceptions continue. And looking at all these things, that even institutional care doesn't deal with the stigma and ostracization, and the family members hesitate to take them for treatment. And so when we look at all this, the best is to use or to utilize community stay and help them to get treatment and improve. Okay, so basic needs India, that's what we believe. And we have been working in the field of community mental health for last 22 years. So our motto is not to admit, unless it's desperately necessary, not to admit anybody in the hospital, but retain them in the community and build the services necessary for people to recover and provide the rehabilitation opportunities and get them reintegrated. For this, though, next please, next slide. Though it sounds simple, but it's very difficult, but we have to work hard integrating whatever the interventions into the community. Okay, mainly because community has all kinds of the organic support system, it's available. So
You have
it's
2 minutes, Dr. Rajaram.
oh, then you can skip other next Suja. And next slide. Yeah. So we build partnership with local organizations, and we build the capacity of the staff members and also community volunteers identified, and then create lots of awareness programs in the community. And then the volunteers identify people with mental illness, provide psychoeducation, visit homes. And so slowly we build all kind of awareness, and also we strengthen the stakeholders, the government and non-government and the local community stakeholders. When we say awareness and helping them, orient them, and then sensitize them on mental illness and mental health in general, and help people with illness to take treatment, be at home, and the community-based organization do the follow-up, monitor, and as they improve, help the family members to engage them in the household responsibilities, and also improve their life skills and regain the livelihood what they lost, or help them to get into new livelihood. If they are not able to do, then help the family members to improve their lifestyle or their economic background by taking up livelihood. So the entire process takes place inside the community. Because it happens inside the community, the public also understands what is mental illness and how to be supportive with them. And in the course of this project, the entire community is aware of mental health and mental illness, and we feel that that is the best alternative. We need definitely the government system, because district mental health program is the one which helps them to get treated and also provides free medicines. What we do is bring them together, and we also do this, the process itself is advocacy among the community. And we also organize the family support group. So they advocate for the people with mental illness, and they go to the government stakeholders and demand better service. So in the places where you are working, particularly in Orissa, the government has launched the district mental health program in all the districts that you are working. And we work very close with that DMHP. And there's a very good networking, good understanding, and we are able to do this effectively. And when we are able to do it effectively, we wonder why not all of us do it.
Thank you. Yeah.
I think
Yes. Thanks, Mr. Raja. Now we move to Nepal. Mr. Matrika Prasad Devkota started experiencing psychosocial issues when he was 15, but it wasn't till 10 years later that he got with psychosocial support. After his recovery, Mr. Devkota realized that despite having a favorable environment for recovery with his psychosocial issue, it still took 4 long years for his rehabilitation. Matrika is the first person who dared to come out and introduce himself as a person who was experiencing psychosocial disability on national television, and by breaking the barriers of silence in this biased and superstitious country, has become a voice for the voiceless persons experiencing psychosocial disability. In which he wants to help ensure the rights of persons experiencing these issues to a dignified life through advocacy and service delivery. With this vision of mental health and psychosocial well-being for all, Koshish was established in 2008, and Mr. Devkota has been leading the organization as the chairperson, which is working extensively in advocacy as well as comprehensive recovery-based psychosocial support in Nepal. Now, Mr. Matrika will present us the CRPD Community Mental Health Program in Nepal. Over to you, Matrika, and you have 10 minutes.
Thank you, Minatsi, and thank you, Brenki, and thank you for everyone. I don't have so much thing to share. I'll try to be specific. And courses is the Sanskrit word. Courses mean making an effort and or to try. Next slide, please. Especially courses we came after the ratification of CRPDs, and that had the paradigm shift that we are no more patient or mentally ill, but as a right holder. And so that's the new era of CRPD, and course is trying to have all the ways for the implementation of United Nations Convention on the right of person with disability. And still, likewise in the previous presentation, and it is health issue, and but rather than health, it is more problem relatively is more to the barrier that that person have to suffer a lot medically, but relatively the person have to suffer a lot because of barriers and prejudice, and also the legal barrier and the legal capacity is taken away and isolate the guardianship, and in Nepal, isolate in many neighboring countries in South Asia and many part of the global South. Next, please. Next slide, please. And courses model is and bringing the right holder together and then promoting peer support and this isolated group and stigmatized population, bringing together and creating a platform to ventilate the distress. And also peer supports are quite not very organized group. These are, but these peer support people are welcome to join in the self-help groups. And these self-help groups are more toward the community-based organization. This self-help group are formed as a new organization, person with psychosocial disabilities, OPDs. And we extensively work in peer support and self-help groups and further meaningful and effective rehabilitation. And we focus on economic empowerment and in the beginning, and our core fund, and we are the lead experience organization. We are the one designing and implementing and monitoring and evaluating the thing, what is useful for our life, and we're trying to give back to our community. Next, please. Next slide, please. And so the thing is now our progressive realization is going through the only from health lens and focus of the medical model, and and it's not we need to have holistic model, and I'm not saying that we need medication, we need support, but these health support should be linked with the government mainstream services, social protection, education, livelihood. So we are linking this right holder to duty bearer in Nepal, like the local government and provincial and federal government. So we are linking with the mainstreaming services and for the mental health issue as well. And next please, next slide please. We have working extensively, more than 5,000 students are trained about mental health and psychosocial well-being, and also public awareness. We work in radios program, we work in television program, we reach out the entire country. And also we're able to help and so many people who need psychiatric support and counseling support and this kind of support and specialized support also in the community, more than 8,000. Next, please. Next slide, please. And we also work with extensively in the local system from the female community health volunteer. They are the grassroots body. And also we work in the education system and also training teacher. As well as we are working with duty bearers and parliamentarian, judges, bureaucrats, and constitutional bodies members sensitized about the legal provision of the rights guaranteed by the United Nations Convention on the Right of Persons with Disabilities. We are also working for the reform. So, like all discriminated laws, they are related with the mental health, psychosocial issues. We have a file in the Supreme Court for dismissal of abolishment of this kind of a discriminative provision, and also parliamentarian for the legal harmonization in line with United Nations Convention on the Right of Persons with Disabilities and other human rights treaties. Next, please. And also, we are able to help more than 1,000 women who were abandoned in the street and with violence, abuse, and and we are helping them extensive support and long run, and these women are rehabilitated in their family and communities and with effective and meaningful inclusion. Next, please.
You have 2 minutes, Matrika.
Okay,
You're done.
I'd like to recap. One of thing, like I'd like to share my lived experience. Treating just people is not enough, but treating with the structural stigma barrier, and rather than people with the mental health issue, the problem is within the family, within the society, within the system. And so we must focus on destigmatizing, and also these people are being advocate and activists, and these people are running the peer support and self-help groups. And now we are now training to the professional what is useful for the people, rather than what people, what people we think, but what people need. And so we are also training in line with United Nations Convention on the Right of Persons with Disabilities for quality and dignified and effective and meaningful participation of the right holder. Thank you so much for this opportunity. If I have any questions, I am here to respond.
Thanks, Matrika. We'll get back to you with the questions during the question hour. Now, I request Suja to play a short video of Naveen, and we thank Naveen for helping us with this. Suja? And one request, I do not want people to put anything in the chat box during the session because it's very difficult for the interpreters.
నా పేరు నవీన్, నా వయసు 10 సంవత్సరాలు, నా ఊరు ఎర్రగుడి, నా 5వ క్లాస్ చదువుకుంటున్నాను. నాకు ఇష్టమైన సబ్జెక్టు తెలుగు. స్కూల్లో నా ఫ్రెండ్స్ ఉన్నారు, వాళ్ళ పేర్లు సిద్ధు, పురుషోత్తం, మనోజ్. మా తల్లి స్కూల్కి ఎత్తుకొని పోతుంది, ఎత్తుకొని వస్తా. పండుకొని లేలేను, మా అమ్మ వచ్చి కూర్చోబెడుతుంది. మొహం కడుక్కోలేను, స్నానం చేయలేను, బోధినలేను, అన్నీ మా తల్లే చేస్తుంది. నేను పెన్ను కూడా పట్టుకోలేను, బళ్ళో నా ఫ్రెండ్సే పట్టిస్తారు.
నా పేరు జమున, నాది ఎర్రగుడి, తుగ్గిల మండలంలోకి. నేను కూలివై బతుక్కుంటున్నా. పాప పేరు కీర్తన, బాబు పేరు నవీన్. నా 2 పిల్లలకి మెదడు పక్షవాతం. పాపని హాస్టల్లో చేర్పించినాను. పాప అక్కడ చదువుకుంటుంది. నవీను పడుకొనే ఉంటాడు, మనిషి లేకుంటే సాయంతో లేడు. నేను లేపి కూర్చోబెడితే కూర్చుంటాడు. నాకు 2 పిల్లల కూలి కూడా పోయేకి కాదు, ఇంటి పిల్లోని చూసుకొనే ఉంటాను ఇంటి దగ్గరే. పాపకు 5,000, బాబుకు 3,000. ఆ పింఛన్తోనే పిల్లలు చూపించుకుంటా ఇంటికాడే బతుకుతున్నాను.
గ్రామంలో నాలాంటి పిల్లలకి వసతి కల్పించాలి, ప్రభుత్వాన్ని కోరుకుంటున్నాను.
So as we move from services for persons, community-based rehabilitation services for persons with disabilities, and also with the experience of persons with psychosocial disability being in the leadership position, we now move into the next service, which is support services for persons with disabilities and the experiences of carers and the burden on the carers. So our next presenter will be Anil Patil. Anil has over 25 years of experience in the international development sector as veterinarian, development practitioner, grant maker, and trustee. Anil established Carers Worldwide in 2012, using his personal experience and passion to transform the lives of unpaid family carers in low and middle income countries, acting as catalyst through a partnership approach. Currently chair of the structure and funding working groups of the International Alliance of Carer Organization, Anil's work and its huge potential for social impact has resulted in him being the recipient of several awards, notably the International Ashoka Fellowship. Now, Anil will present us the caring for caregivers. Anil, you have 10 minutes.
Thank you so much, Mrs. Balasubramaniam, for that brief introduction. I'm guessing you are able to see my screen.
Yes.
Thank you. Happy New Year to everybody. And I must congratulate both the speakers for their excellent work with people with mental illness and their family members in the community, one from India, another from Nepal. So I know both of them very well. So now I would like to take you to the other side of the coin, which is family carers who play a significant role in terms of rehabilitation and empowerment, whole advocacy work, and they play a very, very vital role. Unfortunately, the caring has, even though it is, they are very proud to be caring for someone they love dearly, but it is having a huge impact on their own health and well-being, economic situation, physical health, emotional health. So I will be sharing about our work with family carers in India, Nepal, and Bangladesh. And I'm delighted one of our partner organization is also here, Sacred, Mr. Tippanna, with whom we have been working last 10 years. And delighted to see Navin's video and how her mother is able to provide that support, and now he is able to go to school, and the transformation it has been for both of them. So when I talk about carers, what do we mean by carers? So it is a very broad definition we use. Carers means an individual of any age who cares for or nurses a relative, friend, or a partner, requires help due to physical, mental health, and disability and all. It's not just only disability, but also on the elderly and substance misuse, palliative care, and all. Friends, in low and middle income countries, carers are invisible. Earlier, Rajaram was talking about how the mental health is being invisible, and they feel more isolated and they are vulnerable as well. So impact of caring, the issues and challenges carers are facing, huge issues are, there is a huge list of things are there, but I have picked up few things. One is health is being impacted significantly, their own health, physical, mental health, emotional health. There are family issues, relationship issues are there, and significant impact on their finances. If they are working, they are losing a job, unable to hold the job, and reduction in earning. And there are so many young carers are there, no fault of their own, end up caring for either siblings or parents. Due to that, they're missing out their vital education. One side we talk about right to education, other side, these children, young carers, child carers are missing from their vital education. Of course, having a significant reduction in their social contacts, unable to carry on social commitments. So I want all of you to spend just 30 seconds on this slide. In India, for example, we have a population of more than 1.4 billion population, and this is the 2011 census statistics. More than 12 million people are with severe mental illness, and people with dementia, and people with disabilities. All of these adults and children, all of them have a carers. But we just don't know how many carers are there in India. On the contrary, in the West, for example, in UK, there are more than 6.5 million family carers are there. 1 in every 8 adults are carers. The contribution made by the carers to UK economy is 193 billion. That is the study done by London School of Economics and other carers organization in UK. If I apply that statistic to Indian context, friends, there is going to be minimum 170 million carers in India alone, 2.5 times the size of Karnataka population, only carers, but we just don't know how many are there. WHO, World Health Organization, forecast by 2030, there is going to be 400% increased in need for carers. So what I'm trying to paint a picture here is we are literally sitting on a bubble. We don't know when that bubble is going to burst. It is time for us not just to provide the support to a person needing the care, but also please include carers, not just to transform the skills and provide the information whom they're caring, but also address their own issues and challenges and difficulties they are facing day in, day out. Then you are addressing both sides of the coin. Then you are enriching the family environment within the community. So in the absence of statistics, we started collecting the data in South Asia. Just 89% of carers are feeling anxious and depressed. One side, people who have been identified and diagnosed with mental health, they are receiving the support. Other side, family carers are having that experience. There is no support. If we don't provide the support to them, they would become the users of the mental health services. Already the infrastructure is not that well developed. So 92% of carers are worried about the finances. And there is no concept of respite or a short break. Like you and I, if it is a Saturday and Sunday or any festival, we take time off, spend time with the family members. Unfortunately for carers, they don't have that option. They can't go out and spend time with friends or other family members or relatives. So this is the situation. Again, majority of carers are women. 84% of carers are women. In some countries, for example, in Bangladesh, 97% of carers are women caring for their loved one. And many of those carers are elderly women. Again, they themselves need a help, support, and assistance. They are burdened with caring for someone they love dearly. This is real situation. So it is so important. What I call is carers are partners in care. Please, I want everybody on this virtual platform to just to think and reflect within your own families or within your community, not just to focus only on person needing the care, but also include the carers. And of course, we all know how important the professional's role is. I would say that 80 to 85% of the work is done by the family carers. And we as a professionals, maybe 10 or 15%. When the changes have occurred, I'm taking entire credit. We're not giving the credit to the carers. So if you just start recognizing that critical role they are playing and appreciating, then really magic happens right in front of you. So in 2012, with that background, I established this Carers Worldwide. We are still the only organization strategically, not just raising the awareness of the needs of unpaid family carers, but also providing the support to carers through our partner organizations. I'm going to skip our vision and mission statement. We have very ambitious vision and mission. You will be able to read through our website. We have all that information available. So we act as a catalyst to bring systemic changes in the countries where we are working by building the evidence, by working with policymakers and other academicians and all. And the second one is changing the attitudes in the community or families and promoting support for carers.
You have 2 minutes.
Sure. This is a simple model I have come up with to address those issues. So one is carer support groups, how we can reduce their loneliness and isolation. For that, we have promoted more than 750 such groups are operating in 3 countries now. 92% of carers are participating in that and feeling we are connected, and support system has been established and making caring visible. To address the carers' health issues, we organize a specific health camp, whether it is mental health or a general health camp. Even more than 400 carers have been trained as barefoot counselors, and each barefoot counselor is connected to another 20 carers. In that way, we're able to address their emotional health issues. And we have promoted more than 30 community caring center. Through that, we are offering respite and a short break during the daytime. And when we started the work, only 30% of carers had a regular income. Today, more than 80% of carers are earning an income along with the caring responsibilities. And finally, we promoted a platform for carers to advocate for their rights, advocate for their needs, advocate for the services. We have 15 carers organization, registered organization, and 2 exclusive carers cooperatives to address their financial sustainability issues. So here is our impact. You can look at before and after. And when we started work, 97% of carers were living below poverty line. Now it has come down to 22%. And 61% of carers were having depression and anxiety. That number has come down to 9%. These are independent evaluation done. And recently we commissioned last year about the impact of our work in all the 3 countries and the return on social investment. Every pound, every 100 rupees investment return is nearly 800 rupees. This is again an independent evaluation carried out by MZN International, which is a European consultancy firm. So friends, I just want to take another 1 minute. So in terms of systemic changes, we were instrumental in bringing 2 landmark policy changes, particularly from the carers' point of view. Rights of Persons with Disabilities Act 2016 and Mental Health Bill Act 2017. For the first time in history of India, both of those act recognizes support to caregivers. And you will be delighted to know Karnataka government has recognized carers worldwide as a nodal agencies, and through our work last 3-4 years, and Karnataka government is providing caregivers allowance. Of course, it is at a district level, headquarter happening. We want that to happen in everywhere. More than 6,000 carers were able to receive that allowance. And we also advocated and promoting caring itself is a job under Mahatma Gandhi National Rural Employment Guarantee Act. And through that, more than 8,000 carers were able to access. Of course, now the file is at the central government. We hope that during this year, they will be able to discuss and review and hopefully issue a new guidelines. And in Karnataka, again, 5% reserve fund at Panchayat level being used to support economic empowerment of carers. So friends, what I'm trying to say is our intervention is like a drop of ink in a bucket full of water. You don't need a whole bottle of ink to change the color. Just a little bit of support, really magic happens, right? So our learning has been to healthcare system, carers are the unpaid army keeping everything going on. To service providers, they are the potential catalyst to therapy success. To doctors, they are the expert by experience turning treatment plan into realities. and to the patient. They are the indispensable mother, husband, wife that make each day possible. We started with just 250 carers. Today, we have transformed the lives of more than 150,000 in just 10 years' time. And we have a very ambitious plan by 2030 to reach more than 10 million carers through our direct
Thanks,
work
Mr.
and
Anil. I
indirect
think you have to
work.
definitely wrap up.
Thank you. Thank you so much.
Thank you very
Happy
much.
to take questions.
Yes. So, Venki, now it's 8:30. Do we have time for questions?
Please unmute change. At least for 5 minutes.
Okay. Anybody, if you have questions, please raise your hands or you can put it in the chat box.
Meenakshi, I have put a question in the chat box.
Okay. Okay. Are you working with the government to play the role of carers and also working on social model? Working on social model so that the need for individual caring is minimized to a certain level. So that is
Thank
to
you.
understand it.
Thank you. Thank you, Rajol, for that questions. Yes, we are working with the government, particularly in Karnataka state, I would say. Very closely, we are working with the Karnataka government. As I said, we made several recommendations and guidelines provided to Karnataka government. You will be delighted to know, because of our work and Karnataka government were able to see our work on the ground. And this year, they have just issued a draft letter to us saying that they are going to promote more than 6,500 carers group in Karnataka. To not just to make visible, but how they can support and connect with each other. And again, Tamil Nadu government just recently started providing the carers allowance. Last month, they have issued a order like 1,000 rupees for people with the severe disabilities and severe mental illness. In terms of social care, that is what we are working towards. That is part of our plan. So we are going one step at a time. And would be more than happy to hear from you as well, Rajol.
Thank you.
In India, we are working in Karnataka, Andhra, Tamil Nadu, Jharkhand, and Odisha, 5 states.
Okay. So there is a hand raise. Yeah. Mr. Tum.
Mute, currently unmuted. Hold the same button. All right, thank you very much, and thank you for the opportunity, and thanks for the good presentation, especially the last presentation. I just have a question in the last presentation. You mentioned about care allowance. I just wanted to understand who qualify for this allowance and what is the qualification? How do they qualify for someone to receive this care allowance? Thank you.
Yeah, thank you so much for that question. At the moment, it is carers who are caring severe disabilities who are given a certificate more than 70% and above. They are the one qualified and living below poverty line.
Okay, there is one more question in the chat. Do you work in Uganda, the carers worldwide?
That is part of our next strategic plan, and we would be delighted to meet with you. And certainly, we have a plan to expand our work in other Commonwealth countries. So
Thanks.
by 2030, we want to work in 20 countries.
Okay, the next person is Nitzan Ami.
Hi, thank you so much, and thank you to all the speakers who gave the presentation today. I found it very, very interesting. My name is Nitzan Arni. I'm from the Israeli mission in Geneva, and I've been working with Venki a lot in the last few months on a resolution that we are leading here in WHO, in the World Health Organization, about rehabilitation. I thought the examples that came from today's webinar were fantastic. It's really important to see how the work in communities looks like in different parts of the world, and sometimes we are missing this these examples. So all the presentations with the pictures were really, really good. I don't have a question. I just wanted to say thank you, especially for the colleague from Nepal, because I used to live in Nepal. It was very, very it was very emotional to see. So thank you everybody for this really great webinar. That's my comment. Thank you.
Thank you.
Thank you. Thank you, Nitsan.
Venki, there is one question in the chat box. Is it from Smita Sadashivan? Is it the same in all states for carers of people with more than 75% disabilities, or in certain states?
Yeah, no, unfortunately, it is not everywhere. It is just in Karnataka state. So we are taking that experience and learning to other states as well. At the moment, it is in Karnataka and Tamil Nadu.
Okay. So thank you very much. I think we are running short of time and we need to close, and we don't have any more hand raise or questions on the chat box. So I request Smita to give the vote of thanks.
Hi. Oh, sorry, my background is coming. Greetings to everyone. On behalf of the Indian Rehabilitation and Assistive Technology and Indian Disability Forum, IDF, I thank the three presenters for their eye-opening presentations. We thank United Nations, aid agencies, government, civil society organizations, organizations of persons with disabilities representatives for being with us today. We also thank the translators and the language interpreters and the participants for their valuable contributions. Our thanks also go to Disability Rights India Foundation for meeting the cost of sign language interpretation, Hindi translation, and documentation. Thank you, John and Vidya Sagar, for technical support for the webinar. We look forward to your participation in the next webinar. Thank you very much.
Thank you very much.
Thank you very much to everyone. You will get a mail from us inviting you for an open session on the 3rd of February between 7:30 and 8:30 Indian time. You can drop by and share your story or ask questions. So you will get that mail. Thank you for being with us today, and all the best for the 2023.
Thank you very
much.
Bye-bye.
Thank you. Bye.
Thank you.
Bye.
Bye.